Hello again, and welcome back for our second session of CE Live 2026. If you joined us for our first session, thank you for joining for our second. And if you're brand new, my name is Sarah Korsch, and I'm the Director of Training here at LeClaire. So we are about to offer our second of 3 free CE sessions today. We're assuming a lot of you are joining for all 3, so I'm not going to go through the whole spiel about everything, but just wanted to put a couple of the reminders up here. So again, you would have received a separate login for this one. If you're hearing me, then you're doing it correctly. After the session is over, you have to sign out, and that simply involves clicking end on your Zoom session. So as long as you are on this Zoom call for 50 minutes, that is 50, then we obtained your NPN and resident state from your registration, and that is all we need to give you the CE credit. There will be 2 poll questions, the same as if you watched the first session. All you have to do when that poll pops up is choose the answer on the screen. There isn't a right answer or a wrong answer, maybe some that I prefer over others. But that is just the admin that we wanted to give you today, and we're going to get right into our next presentation. So at this point, I'm pleased to have Bill Hepscher from the Canadian Med Store here with us. He flew in from Florida, was able to traverse the ice storms and the winter storms that's going across the country. So we are so excited that he is here in person with us today. So we are going to be talking about prescription drugs. We know that's been a hot topic the last few years. Safe to say it's going to continue to be a hot topic probably for years to come. And what I love about this is that, Bill, you and Canadian Med Store, I know you're going to give us a lot of information on kind of the history of prescription drugs for the CE session, but you also have a lot of solutions, tools that are going to be very actionable for our agents today. So I'm going to turn this over to you.
Perfect.
For the CE session.
Thank you so much. Appreciate it. Thanks for having me. It's an honor to be up here at the legendary LeClaire agency. As Sarah mentioned, I came in from Tampa, Florida yesterday morning, and interestingly, Tampa got down into the 40s yesterday. Those of you that don't know, who are maybe aren't up here in Minnesota area, it was -3 degrees today. So when I flew in yesterday from Tampa and it was in the 40s, as I was driving to the airport, I saw the kids out at the bus stations, and at the bus stops they were wearing parkas and scarves and things like that when it was 40 degrees. You have to understand, if it gets below 70 in Florida, we get a little nervous. And when I drove here to the office today, the kids were wearing the exact same thing at the bus stops. So just kind of interesting. It was -3 degrees today, and the kids were wearing the same things that they were wearing in Tampa when it was in the 40s. So anyway, thanks so much for having me. I'm always a little intimidated when I see the folks that were speaking before me and after me. And the reason I say that is because I don't come from the world of pharmacy, and I certainly don't come from the world of insurance. I started my company, and I started what I think became my lifelong passion and goal to lower costs of prescription drugs for Americans. But I'd gotten to that world because my brother was diagnosed with non-Hodgkin's lymphoma when he was 27 years old, went through a bone marrow transplant. And I can tell you that even almost 30 years ago when that happened, his anti-rejection medications that he needed from his bone marrow transplant were costing about $10,000 per month. And at the time, we were hearing stories about folks that were, mostly seniors that couldn't afford their prescription medications. And if they lived in border states like Minnesota or Michigan or Vermont, they were driving over the border to Canada to buy their prescription medications. And usually it was about 80 or 90% less expensive than what they were paying for the prescription drugs here in the US. So what I recognized is that folks in Tampa, Florida didn't have that geographic convenience. So how could we go about helping them get those prescription medications from Canada? And that's when 23 years ago, we started our company called the Canadian Med Store. So now for over 2 decades, we've been helping individuals and self-funded employers source medications from licensed pharmacies in Canada. So anyway, this is a CE, so I'm not just going to make a commercial and tell you how to use the Canadian Med Store to order medications. What I am going to do is talk a little bit about why the US system is so much different than the rest of the world, specifically different than Canada and Europe. I think the number one question we get when we're working with Medicare agents or brokers for self-funded insurance, or just our clients in general, is once they place an order from our company or from any international pharmacy and they get their medication, And it's the exact same medication that they were buying in the US, but they were able to obtain that medication for 70 or 80% less expensive. They typically ask me, why is the cost of drugs so much different here in the US? So that's what we're going to talk about. And in order to get to that point, we're going to have to give you a little bit of a history lesson to understand why the US system is so much different than the rest of the world and why we're paying so much more for prescription medications. So be prepared for a little history, and then we're going to get into talking about some of the strategies of how you can safely and compliantly utilize international pharmacies to help lower the cost for your clients. So here's the statistic that often when I share this with civic groups, a Kiwanis Club or a Lions Club or a Chamber of Commerce, this is a little bit shocking to them, but probably people in sitting on this call today know this number. In the US, we spend about 20% of our overall healthcare costs on prescription medications. That's a huge number, and unfortunately, it's a number that we can't continue to see increase, but we're seeing it every year. It goes up higher and higher and higher. So when you think about that, every dollar we spend on healthcare, 20 cents of that dollar is going to prescription drugs. The really scary part about that is not only that it continues to grow, but if we look back into the 1990s, when we were first discussing introducing prescription drug coverage through Medicare as Medicare Part D, you'll see that it was only about 7% of our overall costs were going to prescription drugs, and we were already made the biggest change to Medicare with Medicare Part D because of that 7% increase. And if you go back to the 1960s when Medicare was first created, you'll see that the average share of costs going to prescription medications was only 2%. Now that's an important number to remember as we move forward with the slides. Here's something that I think is important for everybody to know, and again, you guys probably are familiar with this, but when you really hear the number, 36 million Americans last year didn't take prescription drugs because of costs. What that means is that people are not using their medications, that they're splitting pills in half, that maybe they're using their inhaler only once a day when they're supposed to be using it 2 or 3 times a day. Maybe they're taking their prescription drug every other day. And as we all know, some people just decide, I can't afford that, so I'm not going to take my prescriptions. When you think about the fact that 36 million Americans are making that choice, understand this. In a population of about 360 million people, that means 10% of our population is literally not taking their prescription drugs because they can't afford them. That means that somebody you go to church with, one of your neighbors, somebody that you know that your kids are going to school with are literally making that decision not to take their prescription medications because they can't afford them. Now, as a society, if we're actually going to get people healthier and we really want to talk about lowering the cost of healthcare, people have to have access to the prescription medications that they're prescribed by their physician. We're not going to lower the cost of healthcare if people are not taking those prescription medications that they're being prescribed, if they're not being compliant on their medication regimen. So understand this, that prescription that the doctor writes in the paper that they hand them or hitting the e-scribe does not do anybody any good if they can't access those prescriptions. And that's the thing that we really have to address here in the United States. Why are costs so high, and what can we do to lower those costs to make people compliant on their prescription medications? And I'm a real believer that if people become more engaged in their healthcare and actually stay compliant, we will actually see the cost of healthcare come down because people will be living healthier lifestyles. As we start to get into speaking about the international stuff, this is a slide that I think is pretty interesting. I know that this comes back from 2017, but the reason that's important is you may remember under the first Trump administration, there was a lot of talk about America First. NATO wasn't paying their fair share. We were paying too much for prescriptions and the rest of the world wasn't. And it really came out of this study that was done. What HHS did is they looked at the top 100 Part B drugs. Now understand I say B like boy, meaning drugs that would be given in a clinic or at a physician's office. But when they looked at those top 100 Part B drugs, what they recognized is that on average, the US was paying 56% more for the exact same prescriptions as countries like France, Canada, England, Germany. Now understand, this was an apples to apples comparison. We weren't talking about some US brand name drug being compared to some foreign generic. We're talking about the exact same drug from the exact same manufacturer, and we were paying 56% more for those prescription drugs than the rest of the world. The other thing that I think is interesting about the slides is sometimes you might hear from friends of yours or clients of yours said, oh, I went on a cruise and I was able to buy my prescriptions at this pharmacy in Belize or at some pharmacy in Asia somewhere. I found this guy online, and he can ship my medications from the Czech Republic, and it's going to be, half the price. I'm not talking about that. We're talking about first world countries. We're talking about countries like France and England and Canada. And I would challenge most people on this call, if you needed to fill a prescription and you happen to be on the UK on vacation, or if Leclerc said, hey, I have this great opportunity for you to go, set up at a Walmart store in UK. I know it would never happen, but you were living there for 6 months and you had to fill your prescriptions. I would challenge most people on this call that you'd feel very, very comfortable walking into a pharmacy in Canada or the UK or Australia and filling your prescription medications. So understand that as we move forward in this conversation, we are paying 56% more for the exact same medication than the rest of the world is paying for the same medications. I'm going to use EpiPen as an example to speak to you guys. Now, I know this is an old story. Nobody really cares about the EpiPen conversation anymore, because now it's available as a generic drug. But most people that work in the industry remember this story about the EpiPen costing so much money. And if you don't know the story, you'll know that the EpiPen was protected by patent. The actual drug had been on the market for almost 50 years, but the pen that was used to give folks the injection, the patent had still been protected here in the United States. So folks in the US were paying $600, $700. Where I live in Florida, an EpiPen was costing about $800 per month. Now understand that $800 a month is a pretty high cost, especially at the time the average American was estimated to have around $500 in their savings account. So the average family who needed an EpiPen for their son or daughter or family member who suffered from bee sting allergies or peanut allergies were struggling paying for those prescription medications. At the same exact time that we were paying $600, $700, $800 a month for the medications, in England they were paying $69 for the exact same product. Now remember, EpiPen didn't have a generic. There was only one manufacturer. So the product that they were getting in England or in France or in Germany was the exact same drug that we were getting, probably manufactured in the exact same facility. In England they were paying $69. In France they were paying $100. In Germany they were paying the most in Europe, about $200 for the EpiPen, and we were paying $600 for that medication. There was an investigative reporter in Buffalo, New York area who heard about this. So what she did is she traveled to 10 different pharmacies in Buffalo, the Buffalo area. She filled the prescription medication, didn't use insurance, just went in and paid cash for it. And she found that the average cost of the medication in Buffalo, New York area was right around $756. She then traveled over the Niagara River, went into Niagara, Canada, went to 5 pharmacies there, or maybe 10 pharmacies there, filled the prescription medications, and what she found was the average retail cost for the exact same EpiPen, just 10 minutes away in Niagara, Canada, was $94 for that exact same EpiPen. So that will give you an example of when you compare cost. Here in Minnesota, we were paying $600, $700, $800, and right over the border, it was probably costing $94 for the exact same product. Now, if you remember Alex Azar, he was the HHS director or secretary during the first Trump administration. Mr. Azar came from the pharmaceutical world. I have to admit that when I first heard that he was going to be named HHS secretary, I thought, well, this certainly won't be good for prescription drug costs. And I thought, this is literally the definition of the fox, guarding the hen house. But I have to say that I'm very, very sorry for those thoughts, because I think that Alex Azar actually did more for lowering cost of prescription drugs and bringing to light some of the inequities between what we're paying and the rest of the world is paying during his tenure. So I actually think he did a great job when he was secretary, and maybe the reason for that is because he was the fox guarding the hen house. Because he came from the pharmaceutical industry, he kind of knew where the bodies were buried. He knew where the pain points were, so he was able to get a lot of things done. But when he was actually asked, when he was going through his confirmation hearings, one of the senators asked him about the EpiPen conversation exactly. And I think his response, whether it was intended or not, I think really goes to tell us why we're paying so much more here in the U.S. than what the rest of the world is paying. And what Mr. Azar responded to the senator when he was asked about the cost of EpiPen, this is what he said. He said, when the patient goes to the pharmacy, they're getting this sticker, they're getting the list price. No patient was ever supposed to pay those list prices, but in recent years, a growing number have been forced to do exactly that. What Mr. Azar was saying in that situation is, here in the United States, we get our health care through either Medicare, Medicaid, the Veterans Administration, or through an employer-sponsored healthcare plan. And what that means is that the actual utilizer of healthcare, meaning the actual patient or the beneficiary, whether they're on a plan through their employer or they're on a plan through their Medicare option, they pay a co-payment for the prescription medication. So on my end, behind the scenes, we saw that the EpiPen was going up from $400 to $500 to $600 to $800. But the average American walked into the pharmacy and they paid a $30 or a $50 or a $65 copayment for that prescription medications. They didn't know what the real cost was on the back end. The reason the EpiPen story became such a big news story is really for two reasons. Number one, it impacted largely children, kids that were allergic to peanut allergies and bee stings. So guess what? The politicians, the political climate, the 24-hour news cycle like that story. Kids can't get their EpiPen anymore. But it really came to light because the average American, if you have to remember, the average American health plan at the time were switching towards high deductible health plans through the ACA. So what that meant is that patients who typically walked into the pharmacy and filled their prescription medications for $35 were no longer paying $35 because then now they were on a high deductible health plan. They didn't have any coverage for their brand name prescription drugs. Remember, EpiPen didn't have a generic at the time, so they were being forced to pay the full cost of the prescription before they actually hit their deductible. So all of a sudden, folks were up in arms. They were calling their congresspeople, they were calling the local news stories, and because it was a hot topic, because it impacted kids, it became a big national story. So much so that you may remember that Congress actually called the CEO of the manufacturer of EpiPen up to for congressional hearings to talk about that. Of course, nothing really happened after those hearings, but it brought it to light. So I always say if there's ever a silver lining behind the EpiPen story, it's exactly that Americans, even if they weren't someone who was using the EpiPen, started to recognize that the cost of prescription drugs were so high because it made such news. So how did we get to this place where we're paying so much more for prescription medications? Here comes a little bit of the history lesson. What we have to understand is that when we talk about the fact that our system is based on an employer-based healthcare system, we have to go back to World War II and understand why that happened. And basically, this is the reason why. During World War II, we saw inflation going up. We saw most of the working-age males being shipped off to the Pacific and Europe to fight the good fight. And there was a shortage of workers. Some workers that worked in certain industries like manufacturing stuff were kept here because we needed that workforce. We know that we had Rosie the Riveter and females stepping into the workforce. But employers needed a way to attract employees and retain employees. The government was concerned about runaway inflation and wage growth. So what they did is they created, for the first time under the War Powers Act, they actually created a freeze on any wages for employees that worked in the government sector or worked in manufacturing that then contracted with the government. So what that meant was employers couldn't increase the wages of their employees, but they had to do something to incentivize them to continue to work. So what the government allowed the employers to do is to offer benefits at a tax-deductible opportunity. So a tax savings to the employer. So what they could do for their employees is they could provide them with life insurance, they can provide them with additional benefits, they can provide them with health insurance, and it would be a tax benefit to the employer to do that. The other thing is that the employees got those benefits and there was no tax to them. So it was like increasing their wages, but they weren't taxed on those wages because they got their health insurance through their employers. Now at the same time, in Europe, once the war ended, there was a big push to provide health coverage, but we have to understand that Europe was really decimated. The infrastructure didn't exist anymore. Not that the United States wasn't impacted in blood and treasure, but our our infrastructure was still here. So we could shift, we're now working in an employer-based plan because of the tax benefits. In Europe, that didn't really happen. And most of the Europeans remembered the young men coming back from World War I with, missing limbs, eyes, ears, and there was really no safety net for them. So there was a big push in Europe to create some type of a healthcare safety net. The other thing is the Europeans were getting an awful lot of dollars from the United States through the Marshall Plan. So we were pushing that money back into Europe to rebuild the European industry, infrastructure, and their healthcare system. Now, much like the tax benefit that we created here in the United States, in Europe, this was only supposed to last for a few years and we would go back to the normal system. But like any government program, once you give people something, it's very, very hard to take them away. So the US system gravitated towards an employer-sponsored healthcare system, where the European system was a nationalized system, and once people got used to that, that's what they continued to want. Now, as we push forward, we get into the late 50s and 60s, and we start to hear a lot of conversation about seniors, mostly retirees, who were struggling paying their health care costs. So that means that people could leave their employer where they typically had health coverage, and now they were going into retirement, and they didn't have a safety net. There was nothing there to protect our retirees from the rising cost of health care. So in 1965, Lyndon Johnson passed the law that made Medicare the program. So for those that were disabled or over 65, they now had a safety net for prescription drugs. Or I'm sorry, not for prescription drugs, for health care. What's interesting to know is that there was no coverage for prescription drugs. And that wasn't because the government was saying, hey, we don't want to give people prescription drug coverage. Remember the initial slide I showed you that only 2% of our healthcare costs were going to prescription drugs. So if you look at the congressional record, you'll see that there was some conversation about prescription drugs, but not much, because at the time, people were struggling paying going to a doctor or their hospital costs. It wasn't prescription drugs that people were struggling with. You have to remember that back then, now we have these amazing drugs like Eliquis and Pradaxa and Xarelto that you all see when somebody is at risk of having a stroke or had a stroke, they take a medication like that. Back in the 1950s and 60s, those drugs didn't exist. People would have a stroke or a heart attack, basically go into the hospital and die within 48 hours, hence some of the midnight rules that we talk about. So going forward, at the time, there was no prescription drug coverage. But as we push forward and we get into the 80s and 90s, all of a sudden prescription drugs become a very big, very hot topic, and there's a few reasons for that. Number one, this is, some of you older folks like me will remember that this is some of the first times that we start seeing drugs being manufactured and then marketed to us as Americans. We start to see commercials and things like that talking about that. We start to see drug companies making a shift from being really chemical companies and more into marketing companies. They're going out to physicians' offices and starting to market these products. Also, we're seeing these blockbuster drugs, amazing drugs that are keeping us alive for longer, living healthier lifestyles, saving people's lives, start to come out in the 80s and 90s. So pharmacology becomes a really far way. All of a sudden, prescription drugs become a very big driver of cost, but also a great part of the healthcare system. People are living longer, more healthier lives. The other thing that happens is the military-industrial complex. You have to remember in the 80s and 90s, we're still fighting the Cold War. Here in the United States, we're pushing a lot of our dollars towards raising our military, fighting the Soviets in the Cold War. Where in Europe, you don't see as much of an increase into that military spending. So now that Europe has kind of brought itself up from the post-war years, they're putting a lot of that money into their healthcare systems. Remember, when I say healthcare systems, I don't mean their hospitals, I mean into their socialized healthcare. People have become used to that, and it's one thing that they really, really like. Just like folks really, really like Medicare here now, they're very, very used to that socialized system, so they start to push their money that way. And that's one of the reasons that you start to see those prescription drugs become so much higher cost here in the United States. But remember this, we're on a employer-sponsored healthcare system. So what that means is our average employee is walking into the pharmacy and filling a prescription drug, but they're not seeing the real cost. Now in Europe, because they're on a socialized system, you'll see the European countries start to say, hey, listen, we're not going to pay for that expensive blockbuster drug. We're going to stay on these older drugs because they're negotiating the price of prescriptions. The other thing they start doing is going to the drug companies and saying, listen, we're not going to pay that much for the drug. If you want us to offer it, you need to give us a lower price. The pharmaceutical companies basically then tell the European countries, hey, we'll give you the lower price, and they shift the cost over to the United States. So the drug prices in the US go way, way up because the US is paying for really the research and development and things across the whole world. So that's where we are in the 80s and 90s. Now I think there's an exciting poll question.
There sure is. All right, so we've reached our first poll question, and it is, which everyday activity feels like it should require insurance? We've got carrying groceries in one trip, which I feel like I'm an Olympic gold medalist at. Parallel parking, I'm also very good at that. Replying to emails too fast, or letting someone borrow your phone. Ooh, this is going to be a really tough one. So again, which everyday activity feels like it should require insurance? Ooh, I'm getting a couple of comments that we should have an E, all of the above. We will also accept E as an answer. And we are close. It looks like parallel parking has taken a brief lead over letting someone borrow your phone. And I think it's going to stay in the lead there. All right, we'll give about 5 more seconds for you to place your answer. And then we are going to turn it back over to Bill.
I would think we should probably add in there, I think we should add in there that you should add an additional rider for Floridians that come up to Minnesota and rent a car and drive in the ice, because we're not used to ice in Florida where I'm from. So let's push forward a little bit further and then talk about kind of the world that we're in. So we get through the 80s and 90s, we start to see folks that are struggling paying for their prescription drugs. So now you're seeing people who are leaving their employer plan. They could go to a doctor, they could go to a hospital. They typically have supplemental coverage, Medicare supplement or something through their employer, but they can't afford their prescription medications. Those blockbuster drugs have raised the cost so much that you'll start to see seniors really struggling paying for their prescription drug costs. Another thing happened right around that same time. AARP did a survey and they spoke to their members and they said, what's your number one concern? And for years and years and years, it had always been outliving their savings. Seniors, you probably hear that still today. I'm worried about running out of savings that I've worked so hard to build up in my retirement. For the very first time, AARP started to see people respond saying that they're worrying about paying for healthcare, specifically prescription drugs. So that starts to hit the radars of a lot of folks in the political world. Now you have to remember, right before the Bush 1 administration, it was the Clinton administration, and the Clintons had tried to push through what became known as Hillary Care. But what was recognized is that basically the Clinton administration made a few mistakes there. They presented it, they didn't do a very good job PR-wise, but the other thing they did was they alienated the pharmaceutical companies and they alienated the insurance companies. So basically those two entities that are two of the largest lobbying groups in DC spent a bunch of money to make sure that Hillary Care didn't become law, and they were successful. When President Bush becomes president, a few things happen. They recognize that AARP poll. They say, hey, that senior vote is really, really important to us. And the GOP, that typically wasn't really one for dictating to private industry of what they wanted to do to lower prescription drug costs or really anything in general, said this is an opportunity for us to make a difference and to pass legislation that could be beneficial not only to seniors but also to the industries that they were friendly with. The other thing that happened, though, was that the Republicans, for the first time in about 50 years, now controlled the White House, and they controlled both houses of Congress. So that means they could get some things done. So what the Bush administration did was they went to the insurance industry and they said, hey, Mr. Insurance Industry, we know you didn't like that Hillary Care stuff, but we're looking at introducing something that's only going to impact Medicare, but we'd like you to get on board with this. And obviously the insurance company said, hey, we don't really think we like that. We kind of like the compensation we're getting now through the employer-based market. We like the fact that people are, having to pay high cost for prescription drugs. And what the Bush administration basically said is, hey, listen, we have about, at the time, I think it was around 40 million people that were on Medicare, and then obviously we started seeing people aging into Medicare, and they said all these people are now going to have to buy a new plan, because what we're going to do is create something called Medicare prescription drug coverage, Medicare Part D, and it's not going to be a government program. It'll be subsidized with U.S. taxpayer dollars, but you guys are going to be able to sell plans to individuals, because we're going to do that through the private market. So the insurance companies said, wow, that's an awful lot of people that we can sell a new product to, and we're going to get subsidized dollars from the U.S. government, and this is the direction the world is going, so yeah, we're on board. They still had to win over the pharmaceutical industry. And the pharmaceutical industry had already felt like they kind of got, for lack of a better term, screwed a little bit when they negotiated with the VA, with the Veterans Administration. They came to agreements that they were going to actually lower costs of prescription drugs through VA coverage, and they did the same for some of the states with Medicaid. So they were paying back these rebates, and they were really not seeing that same money go to their bottom line. So they said, no, we're not interested. We're not looking to get involved in any type of thing that's going to lower the cost of prescription drugs. There was a lot of back and forth, and in order to win over the pharmaceutical industry, what the Bush administration did in the legislation signed in 2003 was actually make it illegal for Medicare to negotiate prescription drug prices with the drug manufacturers. So let me just say that again. The largest purchaser of healthcare in the United States, being Medicare at the time, basically told their supplier of prescription drugs that we're not going to even negotiate what the cost of these prescription drugs are. We're just going to let you charge us whatever the heck you want to charge us. And that's exactly what happened. I still think the pharmaceutical industry had to be thinking, really? Like, how are you going to do that for us? But that's what happened. Now remember, I told you that we're an employer-based healthcare system, but if anyone's ever been involved in negotiating prescription drug coverage through an employer plan, whether it's fully insured, whether it's self-insured, doesn't really matter. Typically they base reimbursement, whether it's a knee replacement or a treatment of a cold or a prescription drug, they base it on some type of Medicare allowable amount. So typically you have kind of a benchmark for what they're going to charge. So you'd negotiate, hey, we'll give you 2 times what the Medicare allowable amount is in reimbursement, or hey, we'll negotiate 3 times what the Medicare cost is for that same treatment. Well, guess what the benchmark became for prescription drug costs? Really became whatever the prescription drug companies wanted to charge for those medications. So what that meant was there was no incentive for the drug companies to actually lower the cost. When they increased the cost for Medicare, they actually increased the costs as well on the employer side. So now here in the United States, when you see countries like Canada and England and Australia were negotiating their prices down, we basically just said, make the benchmark whatever you want. So not only did it impact prescription drug coverage, but it impacted the cost on the employer-sponsored health plans as well. I'm going to give you an example of a medication that I know you've all heard of. The joke in my office is if you've worked in Medicare for more than 2 weeks, you've had that experience where a senior comes out with their list of medications, or if you're meeting with them face to face, they bring out the shoe box or the Amazon box full of prescription drugs and say, here's my drug list. You've run into that, and you've run into the prescription drug Eliquis at some point if you've worked in this industry for more than, I shouldn't say 2 weeks, probably 2 hours you've run into Eliquis. But here's an example. So before I met with you today, I just went on to GoodRx. I'm not encouraging GoodRx. It's just a good way to say, hey, this is how you look up prescription drug costs. And when I put in the zip code and I put in Eliquis, you'll see that the average price on that Eliquis, even through GoodRx with a coupon or something, that runs around $628 for the medication. Now, Eliquis, the patent has expired in most of the countries I'm talking about. The cost of Eliquis for a generic form of Eliquis through an international pharmacy, whether it's through the Canadian Med Store, I'm sure you can find other competitors that are out there, but Eliquis that we're paying $628 for per month is available through the Canadian Med Store or through international pharmacies for $50 a month. So do the math on that. What that means is that you could fill a year's worth of Eliquis in the United States, through the Canadian Med Store for less than what it costs you for a 1-month supply of the drug here in the United States. So it's a crazy number. What you'll hear a lot about from people, and I hear a lot of pushback with, well, yeah, but I heard that those medications that come from international pharmacies are not safe. I'm here to tell you that I visit my pharmacy in Canada probably 4 times a year. And when I visit the pharmacy in Niagara, I've still yet to see dead Canadians floating over Niagara Falls because somehow, the Canadian government and their healthcare system is feeding them counterfeit medications. They're typically getting the exact same drug from the same manufacturer, probably even here in the United States. One's just labeled for sale in Canada, another one's labeled for sale here in the US, and we're paying in the cost, in the example of Eliquis, 10 times more than what the Canadians are paying for the exact same medication. Now, I do want to warn you, and we'll talk about this a little bit when we get into strategies, that you don't want to just send a client to somewhere and say, hey, go buy your medications when you get off the cruise ship from the little kid that's selling chiclets and maracas in one hand and he's selling you your Eliquis in the other hand. You probably want to be cautious about that. You don't want to just respond to a spam email from somebody. You don't want to just go to some cold call that you get from somebody saying they're ordering from the American pharmacy, but they can get your prescription drugs for so much less expensive. You want to make sure you're dealing with an actual company, an actual brick and mortar company that operates out of Canada or England or Australia, something like that, where we know that the healthcare system is exactly the same. The other thing I always like to share with people when they say, but we can't certify that the medications that come from Canada are safe. I always bring up to people that, last year, it might be a little bit different this year because of tariffs, but we imported $20 billion worth of meat and poultry, grains, fruit from Canada. I challenge that people on this call, when you go out today to your grocery store, whether it be Publix where I live or Kroger or whatever you guys use up here, go to the seafood area and you'll look, and I guarantee you that you'll see something like farm-raised tilapia from Vietnam, and you'll see previously frozen shrimp from Belize, and you'll probably salmon from Canada, something like that. So somehow, the powers that be want us to believe that they can certify that farm-raised tilapia from Vietnam is safe for me to feed to my kids, but they can't certify that the EpiPen that's manufactured in the exact same facility here in the United States and then dispensed to a Canadian pharmacy is not safe. It just doesn't make sense. The average person understands that that's kind of a bunch of hooey. It's just not really true anymore, as long as you're ordering from a legitimate pharmacy, in Canada or another country that is coming from a licensed pharmacy. This is Dr. Gottlieb, who was the FDA commissioner during the first Trump administration. And he was asked exactly that by one of the senators during his hearing, one of the hearings that the FDA had to report back to Congress. And they were asked exactly about that, about saying, what if somebody goes to Canada and gets their prescription medication? And Dr. Scott Gottlieb, remember, he was the commissioner of the FDA at the time. He's the man who is basically charged with protecting the U.S. healthcare system and the drug supply. When asked about that, he said exactly that. If an American consumer goes to a Canadian pharmacy and fills a prescription medication, they're getting a high quality drug, probably the same drug that we're getting here in the United States, because Canada has a regulatory process very, very similar to what we have here in the United States. The last thing that we hear when we hear a lot of pushback from ordering a medication from an international pharmacy is that, but we need to spend all this money because of research and development. Now, you have to remember, I just said to you earlier, and my belief as an American is, we don't mind paying for research and development. I don't mind that drug companies make a whole heck of a lot of money, because going back to my brother's story, my brother wouldn't have been able to put the fight that he was able to fight against his cancer without those pharmaceuticals. Those same treatments wouldn't have existed just a few years before my brother. So I think that the pharmaceutical industry is an amazing industry. I think the people that work in the pharmaceutical industry is an amazing industry. I just don't think it's fair that the Americans are basically paying for all the research and development when other first world countries like Canada, Australia, New Zealand are paying such little for those medications. All I'm saying is that we hear a lot of times about paying your fair share. It's time for the rest of the world to have those costs shift, and they pay a little bit more of the cost, so we can bring down the cost of prescription drugs here in the US. Now, the other thing that I'll say when we talk about research and development is that if you look at this chart here, you'll see that on this slide, the red is what drug companies broken down spend in research and development cost. The blue is what they actually spend in marketing. So when you talk about these companies spending so much money on research and development, you'll recognize that most of them spend double or even 3 times more on marketing, which is why we see all those TV commercials now, which is why whenever you go visit your doctor, you'll see a young rep with, when they're high heels that are walking in and bringing in, samples and marketing pieces to physicians. It's the reason why you'll see that a lot of times these educational events that are held for physicians are sponsored by the pharmaceutical industry. There's nothing wrong with that. We're all business people. There's nothing wrong with marketing. But please stop telling me that you need all that cost for research and development when you're spending so much more on marketing dollars, especially when we know that often that research and development comes through grants that the U.S. government and taxpayer provides to the university system, and the pharmaceutical industry only buys up those what they see as successful and marketable prescriptions as they decide to bring it to market. So again, I'm not here to argue with the pharmaceutical industry. I think that they do a great job and we live healthier lives because of that. Let's just be honest about the story that we're telling when we talk about that. Last thing I'm going to kind of say about that, just so you understand, and we'll talk about strategies in just a minute, is I'm not just some crazy guy coming to you from Florida to talk about this. This has been happening for years and years and years. You folks that live here in Minnesota probably know people that have driven up to Canada to buy their prescription medications. The reason I'm really presenting it and talking about it the way I am is because to understand that I don't think that our system is sustainable if we continue down this path of high cost of prescription drugs. Employers specifically just can't pay for it anymore. And us as taxpayers, when we look at these drugs that are coming to market and paying for it through Medicare or Medicaid, it's an unsustainable path that we're on. So we're either going to have to start going to the European and Canadian system, which I certainly don't encourage, because then we're going to see basically where people don't have access to certain products because the government programs aren't willing to pay for them. We need to give Americans access to the best health care that they can get, which is what we get here in the United States right now. It's just unaffordable health care. It's so bad that in Utah, the employer-sponsored health care plan in Utah actually has a contract with a pharmacy or with a hospital in Tijuana, Mexico, that they'll fly their employees down to Tijuana, Mexico, allow them to get treatment, allow them to get certain surgeries, and then come back to Utah because it saves the state so much money. They can fly them to the spot in Tijuana to get those treatments for less than what it costs them to do it in their own state of Utah. Now, I don't know about you guys, and I'm certainly not judging the location in Tijuana, because I'm sure if the state of Utah is contracting with them, they're probably a great healthcare system. But when I hear about trips to Tijuana, it certainly isn't about going to get, I used to hear about trips when I was in college, and people were going to Tijuana for different reasons than they were to fulfill their prescription medications or get their knee surgery. I'm proud to say that in my state of Florida, we became the very first state to actually pass state law. Governor DeSantis basically said if the federal government's not going to do anything about this, we're going to do something about it. And he passed state law that allowed for the state of Florida to actually purchase medications from distributors in Canada to first lower the cost for our Department of Corrections, ultimately then to offer it to the employee sponsored employee state employee plan, and then also to lower our cost of Medicaid. Now that program has been working through with HHS to get that put into place. The infrastructure of it has not really been completely put into place yet, but we're expecting to see that very, very soon, where the state of Florida, as an employer, is going to be looking to go to Canada to fill prescription medications because they're so much less expensive. Looks like we have another exciting question.
All right, all of you out there who've been waiting for poll question number 2. This one's a little bit of a toughie. The unicorn is the national animal of which country? Norway, Ireland, Scotland, or the Netherlands? Is there a correct answer? Oh, sorry. All right, we're going to go ahead and have you pick one of those. Norway, I mean, Ireland, that's got to be the leprechaun, so it's not Ireland, right? Not telling you.
Is a leprechaun an animal?
Bill, that's why we have you on.
I think you just offended a lot of Irish people.
So my apologies to any Irish people joining us.
Or leprechauns.
All right, Netherlands seems to be the predominant winner. 11% went with Ireland. Is the answer Netherlands? Oh, wow. All right. Well, spoiler for those who didn't choose Netherlands. Looks like that is the correct answer. Scotland. Just kidding. It was Scotland. Good thing there are no wrong answers. All right. So now we've all learned much more today, and we're going to turn this back over to you.
Thank you very much. I should have thought about that, and I could have figured out what the national animal of Canada is. I'm not sure. Probably
The goose?
the polar bear? I don't know.
Polar bear?
I'm not sure.
All right. We'll get back to you.
One of my main pharmacies that we work with is in Winnipeg, and I can tell you that when I go up there and visit, there's always, no disrespect to Winnipeg, but there's not really much of a reason to visit Winnipeg, I don't think, other than to get your prescription drugs for less expensive. And I think the other thing is to go up to Churchill, which is way, way north Canada, and see the polar bears. So I haven't done that trip yet, but I do visit Winnipeg quite a bit, so we're used to the cold weather that you guys are getting here in Minnesota. So again, just to talk to you and tell you, that's just some crazy guy. This is a statistic that I think really makes people open their eyes, especially if you not only work in Medicare, but maybe in your agency you also do some work with self-funded employers. There's currently over 5,000 counties, municipalities, school boards, private employers, labor unions that are utilizing some option of filling their prescription drugs through international programs to help lower their costs. So it's not just seniors, it's not just folks that are uninsured. You're seeing actual employer-based sponsored plans that are saying we need to lower the cost of our prescription drugs, and if we can get the exact same drug from a pharmacy in Canada, we're going to implement that. So much like the state of Florida is doing for their health plan, you already have about 5,000 counties, municipalities, school districts, private and public entities that are pushing that forward. This is the one that I think is probably, I don't want to say surprising to people, but I think it makes folks realize that, this isn't a new thing. This isn't just Bill from Tampa, Florida telling you this story. This isn't some crazy, Bernie Sanders guy who's, leading, bus trips over to Canada. Over 25 million Americans, according to the Kaiser Family Foundation, fill their prescription drugs through an international pharmacy. So it's not something that's not happening. I'm sure when you talk to your clients, if you want to talk to them about utilizing the option of filling through international pharmacies, most of them are going to be familiar with getting their prescription drugs from Canada. When I started the company 23 years ago, it was something that if you didn't live here in Minnesota or Maine or Michigan, you probably weren't all that, understanding of. But now I think people understand that getting those prescription drugs from a pharmacy in Canada, let's say, is a safe and affordable option. I think the average senior too, when you think about when I started my company, the average senior wasn't walking around with a smartphone in their hand or with a tablet. Back in the day, I used to ask them, hey, can I get your email address so I can send you a receipt? And they would say, yeah, but could you call me first because I need to plug in my internet because they were on an AOL account. You younger folks won't remember that, but it would take 2 days to upload a picture of the grandkids. So they would say, yeah, call me first because I need to unplug my phone and then plug in my internet to do that. So totally different than when you see a 65 or 70-year-old today who are leaving the workforce, used to email, used to Google, used to Amazon shopping, used to that type of thing. So I think the mindset of that is we're a much more worldly place than we were even just 20 years ago. So let's talk about the strategies where you could utilize international pharmacies to lower your costs for your clients. One thing I want to make very, very clear is understand that utilizing the Canadian Med Store or any international medication strategy is not meant to replace Medicare Part D. What we consider ourselves is another arrow in your quiver when you sit down with that client that you can't fix the problem with their Part D. Or somebody who maybe when you pick their Part D plan, now things have changed. We're there to help fix that problem and target that problem until the next enrollment period comes up and you can help folks maybe pick a plan that's more suited for them. But we're certainly not here to replace a Medicare Part D plan. Medicare Part D still has to be in place, whether it's standalone through a supplemental plan, whether it's on their Advantage plan. You still need to have those conversations about Medicare Part D with your clients, because quite honestly, there may be certain drugs that we can't source from a place like Canada or England or Australia. That prescription drug coverage has to be in place not only to avoid the penalty, but also to make sure if that catastrophic issue happens, you want to be able to shift them over to that Part D plan and keep that in place. So understand that when I'm talking about these strategies, this is not intended to replace a Part D plan. It's intended to work with you on those type of things. So how would that work? You know, we saw the changes just last year with the IRA, and we really thought that that was going to be something that was going to maybe cause us to go out of business, you know what I mean? And I always said that when I started my company, if we can actually lower the cost of prescription drugs, and that puts me out of business, I always said, heck, I can be a bartender, or if you guys can sell insurance, can I shift over and start selling insurance as well? But guess what? 23 years later, we're not only still here, we're not only still growing, but the last 2 years since the IRA has been our busiest years ever. And what I think we saw there is a lot of times those prescription drugs that were covered on plans now were at such high cost. Maybe there was new deductibles, the premiums went way high. The share of costs were so much more. So we actually saw the shift there when agents started to use the strategy, and we saw an increase in our business. So let's talk about that. When we talk about the high premium, when you're looking at plans now compared to maybe just a few years ago, when you look at a drug like Eliquis, you might look at a Part D plan and go, man, this person's taken 5 drugs, 4 of them are inexpensive generics. I can get them on a very inexpensive Part D plan, but that Eliquis or that Januvia or that Janumet are causing me to have to put them in a high cost premium, an $80 or $100 a month premium just to get that drug covered. Well, not necessarily. A lot of the agents we work with say, heck, I know I can get the Eliquis or the Januvia or the Janumet for around $50 per month from Canada. That's the same cost as my copayment's going to be anyway. Why don't I put somebody in that inexpensive Part D plan where they can get their 4 generic drugs for probably free or very low cost, and we can get that Eliquis from Canada at $50 per month, keeping them out of ever having to pay that high premium just to cover the one drug. The other one that we all get, kind of like, you've all run into that list from your client, we've all run into that call where you pick the plan, everything's perfect, and then halfway through the year somebody calls you and says, hey, remember that plan you put me in that covered all my drugs? Well, my doctor just prescribed this new drug, Eliquis, Januvia, Janumet, whatever it happens to be, and I can't afford it anymore. It's not covered under my drug plan, or I have to wait till I hit my deductible. That's an opportunity for you to say, listen, we've got a solution for you. Let's order that medication from the Canadian med store or another reputable online international pharmacy, and we can get you covered for $50 a month, and then when open enrollment comes around, let's pick another plan for you. Or what we find a lot of our clients do is once they start going down that road, they say, heck, I know I can get this in Canada for $50. Let's just keep me in the inexpensive drug plan. We see a lot with Medicare Advantage plans, especially this last year when people had to shift from Advantage plans. Everything was perfect. You knew their doctors took that. They liked the plan that they were on. Their physicians were all covered under it. Their co-payments for their doctors were low. But now all of a sudden the drug they were taking wasn't covered under the Medicare Advantage the formulary. Or maybe it was at a very, very high tier and the costs were going to go up, and your client was now saying, well, I have to switch away from this Advantage plan, but now I'm going to have to change doctors to do that. What a lot of agents recognize is, wait a minute, we don't really have to do that. Your co-payment on your Advantage plan was going to be $45 anyway. Let's not switch your Advantage plan just to get your Eliquis covered, because we can fill it through the Canadian med store for $50. Now you can keep your doctors that you're comfortable with. You can stay on the plan that you're comfortable with. The other thing, as we all know, is we see formulary changes. So halfway through the year, maybe when you picked the plan, the drug was covered, now something changes and it's not covered again. Is that going to be something that you're going to be able to help with? Well, probably not if that drug's not covered. Often people have to go through step therapy or jump through a bunch of hoops with their doctor to get the drug covered, and that might take weeks or months for that to happen. Well, remember, Canadian Med Store is another place that they can help you with that. The other one that we see a lot from agencies, owners especially, that are trying to really work with maybe employer benefits people and try to help folks with employer coverage. Maybe that person still works for the employer, but they're moving away from that coverage and trying to get onto a Medicare Advantage or a Medicare supplemental plan, but the holdup is often something like prescription drug costs. So that's the one that we really want to maybe talk about, saying, hey, listen, here's a way that we can help those folks fill that drug through Canada, and then maybe going into a supplement or something like that helps. The other thing is younger spouses. We see that a lot with the person that you can help with a Medicare plan is 65, but the spouse is 5 years younger. They're not going to be on Medicare for another couple of years. and they can now, well, how do we help that person? They're on a high deductible ACA plan. Maybe they're forced to go into a Christian health plan or something like that. Remember, Canadian Med Store is somewhere we can help with that. And the last thing I'll say to agents is what they tell us all the time is that ordering their medications from an international pharmacy actually helps them lower their cost for the employee, or I'm sorry, for the beneficiary. And often when you're trying to help them with another product that's going to be a lot more compensation for you versus a Medicare, supplement plan, or even a Medicare Part D plan that doesn't pay very much, and from what I hear from a lot of agents pays nothing. This is a way to help save that money and find those dollars to help them with that final expense plan, with that cancer plan, with that dental plan that maybe they couldn't afford before. So when you find that extra $2,000 you just saved that person, I think it helps you then cross-sell to some of those products that are going to be beneficial to the client, but also help pay you a lot more in compensation. Thank you so much for having me. We didn't get time for questions, but any of those questions that you guys put up, we'll make sure we get back to you ASAP on answering those.
All right. Well, thank you so much for that presentation. We did have a lot of questions in the chat and the Q&A, and many of them were just about what the process is to start utilizing Canadian Med Store, how it works. Many of them are like, I thought it was illegal to go over to Canada. So I think we are out of time for this one, but we're going to make sure that we have the information that you can get in touch with Canadian Med Store. You can reach out to LeClaire. We'll make sure you get that contact information. I wanted to make sure I noted we had many people in the chat saying that you did a fantastic job.
Thank you.
Someone was like, he's a really interesting guy. And I would say the other top comment.
That could be too. That could be, it could go either way, right?
I took it positively.
Okay.
Yes, it was a positive text. The other big one that I have to mention is the national animal of Canada. Do you have any final guesses? It starts with a B.
Beluga whale.
It is the beaver.
Oh.
But we could petition to change it to beluga whale.
I think the beaver's a good one. I like that.
Fantastic. Well, we'll make sure we get all of that information to you. Again, just a really fantastic presentation, and I think people have a lot of great information and action items to take from there.
Yeah, and reach out to LeClaire, and obviously you guys can get them in touch with us, and we'll get back to you with all those questions. Sorry I went so long-winded, but there's a lot of information there.
There was a ton of information. You did exactly what we wanted you to do. So at this point, we have a couple of slides I'll leave up here for just a second. Just a reminder, I know it's a little confusing. You don't have to sign out. You can literally close out your Zoom at this moment to stop listening to me talk, and we will count you for the 50 minutes of credit. But otherwise, if you wanted to see a couple of these slides, just some information on events we have coming up. Otherwise, feel free to close out of the Zoom. You've got a 15-minute break to go refill whatever beverage you're consuming at this point. Make your plans to head to Canada to get those prescription drugs. And then we are going to join you in about 15 minutes for the next one. And I just saw something come up where they wanted the Canadian Med Store contact information. So I'm going to leave this up for another minute, and then we'll close out of the Zoom. But Bill, thank you again.
Yeah, and just please let us know if you reach out via this slide. Just let us know that we met you through LeClaire, so we know where you came from. We know how to track you correctly and how to reach out to you if we need you.
And if the phone lines or the email is bombarded with inquiries, we know that's from all these LeClaire agents.
That's right.
All right, we'll leave this up again for a minute, but feel free to exit this one, and we'll see you in 15 minutes.